Fibrotic HP. Coexisting lung fibrosis and signs of bronchial obstructions are highly suggestive of fibrotic HP. So, how we see lung fibrosis? Lung fibrosis in HP most frequently manifest as irregular fine or coarse reticulation with architectural lung distortion, sometimes with subtle thickening, that can be seen alone or in association with traction bronchiectasis in areas of ground glass. So basically lung fibrosis and signs of bronchial obstructions would be there. Honeycombing can be present and it is often described as minimal, but extensive honeycombing in severe form of fibrotic HP may also be there. So chest HRCT scan, features of fibrotic HP pattern, same as that of non-fibrotic. They divide into typical, compatible, and indeterminate for HP. We'll focus on typical. So typical HP pattern is suggestive of diagnosis of HP and it requires a HRCT pattern of lung fibrosis. In one of the distribution, at least one abnormality that is indicative of small airway disease. So how we are going to see the lung fibrosis? Irregular linear opacities, coarse reticulations with lung distortion, traction bronchiectasis, and honeycombing may be present but do not predominate. And distribution of fibrosis could be both axially and craniocaudally, or mid-zone predominate or relatively speared in lower lung zones. So HRCT indicative of small airway disease, as we previously mentioned, ill-defined centrilobular nodules and or ground glass. And mosaic attenuation, 3 density pattern or ear trapping often in lobular distribution. So we know 3 density pattern is head cheese sign. Now compatible with HP. Compatible with HP pattern exists when HRCT pattern or distribution of lung fibrosis varies from that of typical HP pattern. The variant fibrosis should be accompanied by signs of small airway disease. Variant of pattern of lung fibrosis, UIP pattern or extensive ground glass. UIP pattern basal and subpleural distribution of honeycombing with or without traction bronchiectasis. So if you are seeing this kind of a pattern, this is not typical of HP, it is UIP pattern in HP which is compatible with HP, or extensive ground glass with superimposed subtle features with lung fibrosis. So we are going to see predominant pattern like peribronchovascular subpleural areas, craniocaudal upper zones. HRCT abnormalities indicated of small airways are ill-defined centrilobular nodules or 3 density pattern or head cheese sign. Other than that, other patterns, UIP pattern, probable UIP pattern, indeterminate pattern for UIP, fibrotic NSIP, or organizing pneumonia-like pattern, they are indeterminate for HP. Now coming towards the histopathological features of fibrotic HP. Fibrotic HP differ from non-fibrotic HP in that the underlying chronic interstitial pneumonia and bronchiolitis is complicated by fibrosis. Typical histopathological features of fibrotic HP include subpleural and centriacinar fibrosis with or without bridging fibrosis that spans both subpleural and centriacinar regions or neighboring centriacinar fibrotic lesions. So basically fibrosis. Now coming towards some HRCT patterns. As you can see, typical HP and compatible with HP HRCT patterns. The non-fibrotic typical HP patterns characterized by centrilobular nodules, mosaic attenuations, ear trapping, Or on expiratory scan, the non-fibrotic compatible with HP pattern is exemplified by uniform and subtle ground glass opacities and cyst. Fibrotic typical pattern consists of coarse reticulations like in E and minimal honeycombing in random axial distribution with no zonal predominance. F. Small airway disease fibrotic compatible with HP pattern varies in distribution of lung fibrosis. G. Upper lobe predominance. H. Central or peribronchovascular predominance. I. Fibrotic ground glass attenuation could be there. Now, what is the diagnostic criteria? The diagnostic criteria for HP provided in this guideline emphasize the importance of three primary domains: exposure identification, which is very important, via clinical history, via questionnaire, via serum IgE testing, or specific inhalational challenge test, imaging patterns, and Bell lymphocytosis. Histopathological findings with each described in detail in the corresponding session. So let's coming towards this flow chart. Patients with newly detected ILD abnormalities on chest imaging, exposure assessment and chest HRCT scan, Bell with lymphocytosis, cellular analysis with or without transbronchial lung biopsy. Exposure is identified and typical HP pattern on HRCT and Bell lymphocytosis, conduct an MDT, and this is in high confidence diagnosis of HP. If all other combinations of exposures, HRCT, Bell and TBL findings unclear, again discuss in MDT, consider transbronchial lung cryobiopsy or surgical lung biopsy, and diagnose HP as per this figure. This is very busy slide, but the most important take home is that you do first HRCT and see if it is typical for HP, compatible with HP, or indeterminate for HP. Then check for an exposure, do the Bell and check for lymphocytosis and histopathology findings, and might need a surgical lung biopsies or transbronchial cryobiopsies. For example, if HRCT is typical for HP, exposure is positive, but we haven't done the Bell, or Bell is without lymphocytosis, and either no histopath or indeterminate histopath, then this is in moderate confidence. The high confidence will come when Bell lymphocytosis without histopathology sampling. Now, diagnostic interventions. So, in the guidelines, they also discuss certain questions. There were 6 questions. We'll try to answer them, and they try to answer them as well. So, number 1 question was, should patients with newly detected ILD on chest radiograph or CT scan of the chest with or without an overt history of exposure capable of causing ILD in the patient's environment at home, work, or elsewhere be subjective to formal questioning using a questionnaire to raise the possibility that potential inciting agents of HP are the etiology of ILD or the diagnosis of ILD is HP. So the patient's recommendation is for a patient with newly identified ILD whose differential diagnoses include non-fibrotic HP or fibrotic, the guidelines committee makes no recommendation or suggestion for or against the use of a specific questionnaire to identify potential inciting agents of HP. Instead, the guidelines committee recommends the development and validation of questionnaire. So in the first question, they asking is there is any form of questionnaire is available which we can use. In the recommendations, they make no recommendations for any particular questionnaire, but they says that it is needed and we should develop one validated questionnaire so that everyone can use. Pending the availability of validated questionnaire, The guideline committee advocates that clinicians take a thorough history to identify potential exposures and sources in the patient's environment that are known to be associated with HP. So we should take a thorough history, and potential exposure should be found out on history, but we need one questionnaire. Second question. Should patients with newly detected ILD on chest radiograph or CT scan of chest with or without overt history of exposure capable of causing ILD in the patient's environment at home, work or elsewhere undergo serum testing for IgG antibodies against a specific antigen to raise the possibility that potential inciting agents of HP are the etiology of the ILD or the diagnosis of ILD is HP. Should we do or not? So recommendations are for patient with newly identified ILD whose differential diagnoses include non-fibrotic HP, the committee guidelines suggest performing a serum IgG testing that targets the potential antigens. So in non-fibrotic HP, we should do IgG testing against a specific antigen. And for patient with newly identified ILD whose differential diagnoses include fibrotic HP, the guidelines committee suggests performing a serum IgG that targets potential antigens. So with fibrotic and with non-fibrotic both, we should be doing specific serum antigen for IgG antibodies. Question 3. Should patient with newly detected ILD on chest radiograph or a CT scan of chest with or without history of exposure capable of causing HP undergo Bell fluid lymphocyte cellular analysis to diagnose HP? Should we go for Bell? For patient with newly identified ILD whose differential diagnoses include non-fibrotic HP, the committee recommends Bell with lymphocyte cellular analysis. So we should go for Bell to identified lymphocyte with cellular analysis. And for patient with newly identified ILD whose differential diagnoses include fibrotic HP, the guideline committee suggests. So whether it is fibrotic, whether it is non-fibrotic, we should go for Bell and check lymphocytes. Question 4. Should patient with newly detected ILD on chest radiograph or a CT scan of the chest with or without history of exposure capable of causing HP undergo transbronchial forceps lung biopsy to diagnose HP? Should we go for it? So the recommendations are for patient with newly identified ILD whose differential diagnoses include non-fibrotic HP, the guidelines committee suggests transbronchial biopsy. For patients with newly identified ILD whose differential diagnoses include fibrotic HP, the guidelines make no recommendation or suggestion for or against the transbronchial biopsy. Question 5. Should patients with a newly detected ILD on chest radiograph or CT scan of the chest with or without biopsy of exposure capable of causing HP undergo transbronchial lung cryobiopsy to diagnose HP? So committee makes no recommendation for non-fibrotic, and committee concludes that for fibrotic HP we should go for transbronchial lung cryobiopsy. So transbronchial lung cryobiopsy in fibrotic, go for it. In non-fibrotic, no recommendation. This is to be mentioned that it's for transbronchial lung cryobiopsy and this is for forceps lung biopsy. The forceps lung biopsy can go for non-fibrotic and transbronchial lung cryobiopsy can go for fibrotic HP. Question 6. Should patient with newly detected ILD on chest radiograph or CT scan of the chest with or without history of exposure capable of causing HP undergo a surgical lung biopsy? So a patient with identified ILD whose differential diagnoses include non-fibrotic HP, The guideline committee suggests surgical lung biopsy. This recommendation is intended for after alternative diagnostic options have been already used or exhausted. For patients with newly identified ILD, whose differential diagnoses include fibrotic HP, the guideline committee suggests surgical lung biopsy. Same. So if there is no diagnosis making, you can go for transbronchial lung biopsy. Let's come to summary. The guideline committee defined HP and its clinical, radiographic, and pathological features were described. They have classified HP into non-fibrotic and fibrotic phenotypes. The need for thorough history and validated questionnaire to identify potential exposure was agreed on. Serum IgG testing against potential antigens associated with HP was suggested to identify the potential exposures. For patients with non-fibrotic HP, a recommendation was made in favor of obtaining BEL. For lymphocyte cellular analysis and suggestion for transbronchial lung biopsy and surgical lung biopsy was also made. For patients with fibrotic HP, suggestions were made in favor of obtaining BEL for lymphocytes, cellular analysis, transbronchial lung cryobiopsy, and surgical lung biopsy. And they also established a diagnostic criteria. Conclusion: when a patient presents with newly detected ILD identified by HRCT, clinicians should be prompt to elicit a careful and thorough history taking and possibly utilize a formal questionnaire to reveal the possibility of relationship between environmental factor, exposure, and symptoms. Serum IgG antibody testing against potential antigens associated with HP to be performed. BEL could be arranged to see lymphocytes cellular analysis with or without transbronchial lung biopsy. And the information should be utilized with HRCT patterns. And MDD discussion can be done for transbronchial biopsies, transbronchial lung cryobiopsies, or surgical lung biopsies. Thank you.